James, your co-host should be able to share.
All right, I'm gonna get started now. Thank you everybody for coming today. We have a very good case that Dr. Talk did on Tuesday. So we have a patient at an outside hospital, 58-year-old female with the pain in the neck and arms, progressive weakness and numbness in the uppers and 26.
Okay, James, you want to get started?
Sorry, can you hear me?
I can hear you.
Okay, sorry, I'll start over. So this is a 58-year-old
Okay,
female.
James, can you hear me?
Yeah, I can hear you.
We can't hear you. Maybe you're muted.
I'll try calling him. I don't think you can hear you.
Let's see here.
Okay, Ken.
We can hear James.
Yeah. Hey, Dr. Talk.
Yes, okay. Let's get going, please. Yeah.
Okay, yeah. So this is a 58-year-old female who presented to the outside hospital with pain in the neck and arms, progressive weakness and numbness in the uppers in 2016. She had a study with the EMG and nerve conduction study showing possible sensory and motor demyelinating disease. She's also had a cervical epidural steroid injection that helped, but it's been worsening since the September of 2020. On outside imaging, this is the T2 sagittal, and I'll show you here slowly. It was believed that the C6-7 disc osteophyte was the culprit, although there's no T2 edema. It did seem to correlate somewhat in terms of imaging, as I can see in the axial here.
Yeah. So James, if Dr. Reiner is on the line, I think it will be great for her to give some comments on the imaging as well.
I didn't see her yet. Dr. Reiner, are you on the line?
Okay.
But you've got some straightening of the. Yeah, go ahead. No, go for it. If somebody else
Right,
wanted
thanks, Dr. Miller. Yeah. So as Dr. Miller was starting out with, there is of course some straightening and a few disc bulges there below the C4 level, but I think maybe on a slightly more mid-sagittal slice, a little bit higher, near the cranial-cervical junction, I thought what looked like might be some flow voids there dorsally. There you go. Yeah. So, so that might be a slightly more concerning finding, and we don't have a stir here, but sometimes that can be a little bit more sensitive in bringing out any cord edema that can be induced by a vascular malformation.
Dr. Patel, what is stir image? Can you just explain it to everybody? Like, what is stir?
Stir, yeah, the acronym starts for a short time or short tau inversion recovery. If you're familiar with FLAIR, in brain imaging, it's a similar concept, but the timing is different. In FLAIR, we set the timing to suppress fluid. With STIR, which we use in spine imaging, we set the timing to suppress fat. So it's essentially a T2-weighted image, but we've removed additionally the signal from fat, which sometimes improves the sensitivity to the fluid.
Yeah, it's especially good for fluid. One of the interesting things when this lady presented to our clinic in June was that, when they talked about, James mentioned briefly that the outside people had thought the C6-7 disc was involved. The lady also had leg weakness, and she had involvement of muscles in her arm that were at levels above what would be explained by the C6-7 roots. So we had some suspicion going in that the clinical picture didn't fit the what we were seeing, what was reported on the outside, and
yeah. And one more thing that Dr. Sandhu mentioned is that the problem with T2 is that you can sometimes see CSF pulsation artifacts. I'll show you here. Sometimes you can see CSF pulsation artifacts that can sort of confound the imaging evidence. The sequence that is best for this, that is not angio, is a twist sequence that actually shows you, and you can look for that early venous filling. And another tip that he gave us was that you can also try KISS sequence if that's available. that also decreases some CSF pulsations as well.
So you can twist, you can kiss, or you can stir.
Or angio.
There you go.
Yeah,
Shake, rattle, and roll.
so the outside hospital, they did the C6-7 ACDF in April of 2021, which improved her arm pain only. So now she presents to Mayo Clinic on May of 2022 to Dr. Miller and the team with persistent weakness and numbness in the arms, and now she has right leg weakness, and she reports a weight loss over 1 year. And if you, on the exam, she was in a wheelchair from pain, but she's still able to walk. She has severe right arm atrophy throughout, especially in the hand intrinsics. The right upper extremity, most of the muscle groups are noted to be 3 out of 5. And the right lower leg had a 4 out of 5 strength compared to the left in hip flexion, knee extension, and knee flexion. She also had difficulty standing on the toes because of balance issues. Otherwise, she's had no Hoffmans and the reflexes were normal. The next step that we did was get an X-ray to just make sure that the hardware is intact. There's no hardware issues there, no evolving deformities or anything like that that can contribute to this weakness. We got an MRI here again. And as you can see in our sequence, you can see these flow voids a lot better here on the dorsal surface. And it's also very well demonstrated in this coronal slice too. Let's see here, right there. And I have these images blown up so that it's easier to see. So right here, you can see this abnormal or hypervascularity, not abnormal, but. And this is pointing to the flow voids that we've seen. And again, the blue arrows indicate CSF pulsations, but the red arrow here indicates the venous structure that we see on the other slices. So just a question here, if you can take a moment to think, what are these structures that are outlined here in the blue box and one right here? So that's the coronal venous plexus and the medullary vein, and this will be important as we move forward. We have the angiogram of the.
So one second, go back, James. So you have coronary venous plexus or medullary veins. All those are the same. What you have pointed out as medullary vein is a radicular vein. Basically.
Yeah, I've also seen in literature that this also referred to as a radiculomedullary vein.
Well, so what does it mean? So radicular means it goes with the nerve, and then it becomes the medullary vein, basically. So that's why they refer to it as the radicular medullary vein. So the way where you're pointing it outside, this is a radicular vein. So it goes with the nerve. That's the adjective of nerve is radicular. It's root, basically, nerve root, radicular. Okay, now we have the coronary venous plexus. It's the plexus that surrounds the cord, and it's very complex shape. You know, you can draw whatever you want. It will be probably accurate because it's the most complex vascular network that you can imagine for the cord. Okay.
Yep. And I have here the angiogram of the right vertebral artery done here. And I'll show you the blown up slices. I'll just run it through for you guys once here. Yeah. So that's the coronal.
Yeah, and Dave, maybe you want to make comments on this is, I think, your angiogram when you did it for the patient.
Yeah, I mean, you can quite clearly see that there's a abnormal dilatation of some of these muscular branches off the cervical vertebral artery, and then you have the early draining vein, which you can see running up posteriorly and at the level of in the cord. And this is clearly an early venous with high flow, relatively high flow dural AV fistula here, or AV fistula.
And here's for completeness, there's a left vertebral artery injection. I'll run it through once and then I'll show you the slices again.
Yeah, it's a similar idea. And it becomes important because once you identify a fistula, then you need to be sure that you are investigating all of the other possible feeding arteries, because the longer, especially as we know, this lady's been having trouble now for a long time. So the longer these things exist, the more that they recruit. And while in most times there's one fistula point, there are, you oftentimes get multiple feeders. The identification of all those feeders is important, both to make sure that you know where everything is coming from and making sure it is all coming to one point, because occasionally you do get multiple points. But the other is that your options for treatment will depend a little on where your feeding vessels come from and how many of them and what's involved.
Mhm.
Yeah, so what's important here as well is to mention that it looks like the same venous structure that's filling from both sides. So here,
Yeah, good point.
it's reassuring because, you know, whatever is it, this is the same structure but feeding from multiple places. So I trick my, everybody is like, how you call it? What is this? What kind of fistula? So what kind of fistula? Basically, it is a fistula that's somewhere the connections, you assume it's dural, or it could be in the epidural space. Then you have it complex because there's many feeders. So the word complex versus simple reflects multiple feeders versus simple feeders. And it has retrograde. This is like the dural fistula in the brain. We call it retrograde venous outflow because the venous outflow from this goes inside the coronary venous plexus and creates venous hypertension. So the pathology here is venous hypertension. The flow, it's relatively low flow because otherwise you see cord edema and you see the cord congested. And this has a lot to do to what we're going to find in surgery later on, because the flow on those fistulas is very important to know the pattern. So it's a complex fistula. Dr. Miller labeled it as C4 dural fistula, which I think reasonable in this complex. Okay,
This actually brings up a question, Dr. Todd Miller and Dr. Patel, if you're there. So how do you correlate symptomatology versus when you see cord edema?
Most of the edema, most fistula, the stigmata of fistula are two things. So if you're looking for fistula for the board for imaging, there are two things you look for. Number one, cord edema. Number two, flow voids. Cord edema can be caused by many things, but flow voids within the spinal canal are very particular, okay? So those are the two things you look for fistula. Now, the more edema there is, the more symptomatic, and the edema kind of spreads on both sides in the spinal cord, and it's proportional to the venous hypertension, okay? So there's many other conditions that can cause venous hypertension other than fistula, and they can mimic this as well, okay?
Gotcha. One of Dr. Patel, thoughts?
Yeah, I just I agree with Dr. Tugg, especially when the cord edema is diffuse. It may not be quite as illuminating, but I do like to mention, especially if there's some focal cord edema. I don't know if you agree with this, Dr. Miller, but I think sometimes that can help to localize the point of the fistula if the cord edema is a bit more local. So at least give you a point to start.
I think it's true. Well, very often the edema, when you see it, is near the point of the fistula. I think one of the interesting things about this is that when you find patients who come in, and we see this in the in fistulas in the lumbar spine in particular, a lot of the times we'll have patients who come in many times having undergone laminectomy and discectomy, or in this case anterior discectomy and fusion, multiple surgical procedures for presumed deficits related to what are more commonly identified pathologies. I think one of the things that should put you on a high alert, as it was with me, is that these patients, when they have fistulas, as Dr. Talk and Patel both mentioned, that this venous hypertension can extend significantly away from and affect nerves away from where the actual fistula is, so that you end up with patients who have deficits that don't correlate. When you have people who have deficits that don't correlate with the things that you can easily see with the discs or the this lady had facet hypertrophy and synovitis and some foraminal narrowing and all that stuff, but her deficits were more extensive than that, didn't correlate with that. And when I see those things in patients, then I begin to get concerned about things more like fistulas, because the venous hypertension can project the deficit to areas that are far away from from the point of the actual site of the fistula. And the other thing is that you can see that as you can see in this lady, she manifested symptoms before she manifested significant cord edema. So you can see that as well. So the lack of, while cord edema does help, and as Dr. Bell pointed out, can help them localize the fistula, it doesn't, the lack of cord edema doesn't tell you that there's not a fistula.
Thank you. And here, this is a 3D reconstruction. As you can see, again, the right-sided vert injection. And this gives you a very nice view here of the medullary or radicular vein that is coursing up into the C4 canal.
So
here.
this
And
is
you can trace it back up here. Radicular
radicular
artery. And now
That was Dr. Talk's CT or 3D rendering. That was a beautiful addition to this.
yeah, definitely. And then here on the axial slices, there's a couple more things that, first of all, you can see this vertebral artery also giving off some branches to these PO venous structures as well. And as you go down to the canal of C4, let's see here. Right there. So you can see this a lot better too on the axial slice, as you can see that right vertebral artery and the branch going into the foramen. And again, the dorsal hypervascularity that we've seen on MRI, now you can see this fistula coursing all the way upwards like that. So
the value of this imaging is to localize it exactly where it is and see the connections where they are. And I don't know if you still have around, but this patient has a very important anatomical variation, is that you have like two pica. You want to show that as well?
right here, yeah. So as Dr. Talk mentioned, you can see, pica usually comes off the vert, but sometimes you could have a duplicated anatomy where if you have a pica coming off the basilar artery, this can also be referred to as something called Ica pica. So that's what you see right here.
So stay there. I'm just going to annotate here. So here you have Ica is right there. So Ica comes from the basilar. You have a pica, classic pica is this. And this is, I have not seen this before, but this is another pica because it fills part of the tonsil. It's almost extradural. It fills a small portion of the tonsil. And this one fills, so this one fills the medulla and inferior tonsil, this one lateral tonsil. So it's a very important anatomical variations just to recognize, even for spine surgery and other things. As you're opening the dura, you have to be careful when you open the dura. Anytime you're doing, Chiari decompression, those kind of things, this is the area where you work in. That's why you go in the midline, you open always the midline. So as you showed on the expert CT, which is the sequence, the 3D, exactly. See, this is where this vessel originates. And this is what you're showing here are the condyles. Let me remove my annotation. Okay, so this is the, you're seeing part of the condyle. So this is the junction of C1, C2, and this vessel comes at the craniocervical junction. And then you see where it's posterior. It's draped over the cord. Okay, this circle right here is the silhouette of the medulla or spinal cord. Okay, so this is the pseudocircle that I wrote here. So this is the vessel where it's draped posteriorly over the medulla. Okay, so this is anatomical variations that we found also in this patient. So let's keep going.
And this is the virtual reality that really helps not only with education, but also surgical planning. Let's see here. So with this system, I was able to check it out while I was on my vascular rotation. You could remove the, you could actually do a part of the surgery there, like a laminectomy, to see exactly like how the vascularities look like inside. You could look up and down all the way. And here you could remove some of the bone and see some more. And I
So
thought
this,
this was a really
yeah,
cool
so
system.
this one I'm simulating if I do the surgery through a matrix tube and I'm just wanted to go after hemilaminectomy. And I'm seeing what I can see inside the canal just by removing this part. So what you see inside, you see that vein, it's the same anatomy. And then you see the radicular feeders to that vein right there. And that's why I thought that we can do this through a matrix tube surgery, basically, which I have been doing recently for dural fistula instead of the big opening, long recovery. This most patients like this, they leave the second day after surgery. So it felt to me like we can do something like this. I just wanted to see it up front. You know, I like to be ready for surgery before. I don't want to see things unexpected. So I try to know as much as you can know before surgery. You'll be more prepared. So this is the
that's
session.
yeah, that's really fantastic stuff. I mean, as you said, you know, with with the variability of the feeding arteries into a fistula, the ability to to look at it this way, and as you said, the ability to decide whether or not you can do this with a smaller field or a bigger field, it's you know, that's really a fantastic fantastic addition to the diagnostic armament here. Man, it's really great.
And just a quick note. So pause your video right there for a second. So this is a simulation system that, you know, I'm trialing and I'm trying basically. But if you look at this image, I was looking at it before surgery. And if you look at it, you're looking from posterior. And then the vessels that are feeding, you look at them, they're from the left side. So this is not real. This is something. So I called the company. I said, this is incorrect. So you have to always make your own judgment, never rely on technology completely, because I mean, technology, it could be there one day, but sometimes it's behind you as a surgeon. And if you rely too much on it, you lose your surgical sense. It will induce an error. So as you can tell from this is incorrect. The vessel is on the right side. I don't know how they do it. They probably mirror image, and then they took the mirror image of what was acquired, and they do it. But it still reflects the anatomy, the level, you know, and the details are just reversed. So don't rely on technology blindly. Make your independent clinical judgment.
So one of the other things that the angiogram did, as opposed to the or the early angiograms did, was determine the size of the feeding vessels. Again, you'd like to be able to take care of this in endovascular pattern if you can, but you have to determine whether or not the vessels that are feeding are big enough to allow you to get a microcatheter close enough to feel comfortable doing this, or being able to go from a transvenous approach. And, you know, I mean, I remember reviewing this with Dr. Talk once. So we did the initial angiogram, and we both felt that the complexity of this, the location and the size of the feeding vessels, especially as they got closer to the fistula itself, made this a difficult thing to do from an endovascular perspective, with some significant risks. So we thought it was better, was most likely a better surgical approach.
Great. So to be mindful of the second case, we have 5 minutes, James.
Okay. Here's the next question. What blood vessels supply the mid to lower cervical radicular arteries? And basically, just to save time, it's vertebral artery, the ascending cervical branch as well, which also may, it usually comes from vertebral artery or the thyrocervical trunk. Before we begin on the operative video, I wanted to show this image with the metrics tube system and how the planning is done, or the technique that is done. This is docked right at the lamina of C4, and a part of it is on the upper level as well. And with this, you can kind of, this is localizing right into the foramen of C4. And you can see all of these trajectories and angles to make sure if you do need to extend anything like it, that you have the adequate exposure so that you don't have to move this tube around. And you do an axial confirmation to make sure that you're not on the other side, because sometimes it could be very tricky. Okay, so let me share my video now. It's on my other computer. Let's see if that works, okay. So this is through the metrics tube system, and you can see he's drilling out the lamina of C4 there. Part of the spinous process is up here. This is from the right side again. So the head is on the head is on this side. And here's the dural opening in a reverse U-shaped fashion.
Yep. So inferiorly in the screen is your right side because we're routing to the we want to extend to the radicular artery. So this is Dr. Alwala and myself opening the dura, and here we're looking at the foramen, and this is the vein, the initial part of the vein, and this is the nerve roots. So we're dissecting them. We're cutting the arachnoid. Then we had to open the dentate ligament, basically. So here we're dissecting to try to move things around. And this is the ICG. When we did the ICG, the thing that we're looking for, so we look for the first filling vein, and that's your key. The issue is that this was not the first filling vein. It did not fill. And the second thing, you look at the flow pattern. Is it going like this way or this way, anterograde or retrograde? And the vein was not filling in the normal pattern that we saw in the angiogram. So this led to a little bit of uncertainty because, you know, in the angiogram, this radicular vein filled from the outside of the dura to the inside. In this position with the patient prone, it filled from the medulla to the outside. So this is also a hint that why this patient did not have a myelopathy, because this fistula was certainly low flow and the pressure might have been bidirectional. That's why it took her so much time to basically develop those symptoms, and her symptoms are not as severe as others. I mean, many of those fistulas, you see them and the patient declines. In 2 days, they can't walk or something. This patient has been symptomatic for years. So, but I didn't dare to do this like this. I said, I'm gonna decide to open. This patient was very challenging, like with her, just her problem has been so much ongoing, so chronic, family like on their nerves all the time and so forth. So I'm like, you know what? I'm not going back to the OR again. I decided to open. And this is the opening. This is here, taking the epidural venous plexus that was very hypervascular, and here extending the dural opening from our C shape. Now, how you gonna redesign dural opening that you can close completely and integrate without, you know, trying not to use dural patch. So see irrigation, we're releasing arachnoids, very thick adhesions. Here I'm working at the nerve roots, and I explored the level above and below. And here we're teasing out the vein from the cord. And this is the vein on the medulla that was filling first, where I'm right, dissecting right there. And we're straightening the nerve rootlets, each one going from different direction and joining.
And this is the ICG run again.
And still filling the same. The vein that fills first was not this radicular vein, was a medullary vein that you see swiggly right in the center. And then the pattern was centrifugal from the cord to the outside. But at this point, there was nothing else. This was the only thing. And I assured myself that there is nothing else. I cut the dentate, looked anterior to the cord. Here you see us flipping the vein superiorly and to see if there's something underneath it, because with ICG, it's like a scout view from the surface. You'll miss things that are not in your visual fields or hiding underneath. So, and we kept going. Here you see a temporary clip on that vein. We put a temporary clip on it. We continued with SSEP. We moved it away from the rootlets, as you see. And then we put this clip. I like it. It's a very gentle, small clip. And then here I'm lifting the vein up to coagulate so we don't burn the nerve root. And this is the site where we sacrifice the vein, basically. So this is the cauterization, and I usually like to cut the vein because sometimes people say, well, if you don't cut it, the vessel can recanalize through vasovasorum or something. So I routinely cut it. I used to send it for pathology, but when the reports all the time say vessel, I stopped sending it because it's an unnecessary charge for the patient at this point from my perspective. And this is the ICG after ligating the vein. You see the black vein now, it's stagnating. There is no flow in it. The effluent veins towards it, you see them slow down, and partially filling, you see that vessel above it immediately, how it's filling with ICG. And some pulsatile patterns because there's outflow obstruction from that vein. And then you see it on the inferior side. Okay, let me just annotate to you. So James, try to play it, and then here you see the pulsatile flow. Yep, so try to play it now and watch this. This is now the flow trying to move in that direction, but it's occluded. It can't go anywhere. And this is the final view. And this is the dural closure.
And to mention that, the venous plexus is extensive. And so that taking, in general, in a fistula, by the time you go to take that vein, the vein generally very rarely is, well, not very rarely is draining normal structures. You need to be careful about that. But for the most part here, and there's lots of redundancy in the venous plexus. That's work that Dr. Brinchicki up at Rochester and Dr. Wynn down here have been showing with some of the fistula, venous CSF fistulas we've been seeing. So it's you have a lot of room to take veins if you have to.
Yeah. So again, what Dr. Talk mentioned, this is going back to that question, what is unusual about the ICG finding compared to the angiogram? And the answer is a flow direction, because when I was first reviewing the video, I saw that the ICG didn't fill from the radicular and the medullary veins to the dorsal surface. But it was the opposite. So that's why, again, Dr. Talk had to send just to make sure there's nothing else going on.
Wonderful. To be mindful of the second case.
Yeah. So I just want to thank Dr. Talk and Dr. Miller and the radiology team as well. Thank you very much.
Yeah, nice job, James. Thank you for presenting the case. I think it's
very nice presentation.
I'm glad.
And wonderful surgery, Dr. Talk. That's a beautiful dissection.
Thank you.
It's nice. It is very, very nice to have the luxury that I have as an interventionalist, and being able to recognize the things that are going to be not just impossible, but the things that are going to be difficult for me as an interventionalist, as an endovascular procedure, because I have all the confidence in the world that I can turn things over to my surgical colleagues, very talented Dr. Talk and Dr. Fox. It makes my job a lot easier.
We will have to pay you later, Dr. Miller. No problem.
Yeah. Dinner's fine.
Let's move on to the next case for the